AH2. Okay, so define and describe the gas exchange. You should have already done that when you ran into ARF 1, when you talked about TB and COPD, the other, what else did you do in there? Pneumonia, yeah, good ones. Notice the risk factors. What's one of the first ones you're going to notice?
Smoke.
Turning blue, you know, I mean, that's probably the gas being, that's kind of cool. Recognize when they have compromised gas exchange and provide appropriate nursing and collaborations. So, gas exchange is the process of exchanging the oxygen that has to transport to the cells and pick up the carbon dioxide and take it out. Take the trash. Spectrum optimal to impaired. So we're not going to break into groups, that takes too much time in our day, right? So ischemia, is it any different than it is with the MI? Ischemia is ischemia, right? Those cells are not getting what they need and they die off. Ventilation, what is ventilation? Air movement, think about it, when you need to ventilate your stinky smell from cooking fish in the house and burning it, you open up a window to ventilate it and get the air out, right? Ventilation, you remember it that way. Hypoxia, low oxygen, not no oxygen, low oxygen. Anoxia is low oxygen. Okay, transport. Buses transport you. What is transporting what you need for gas exchange? There we go, perfusion. See how that ties into it? Perfusion, okay. Hypoxemia is low oxygen in the blood, not just the cells, just the blood. Okay. Review. We're going to look at a picture and it's going to go over this. So, we have the upper airway, right, above blue, here on up, before it breaks into the bronchial tree. The bronchial tree, then the lungs, is the lower. So it's going to come in, and what's the main purpose of your nose? Filter and moisture and warmth, right? Warms that air, goes down, filters in, goes through the upper respiratory, then hits the lower, goes down into the bronchioles, to the alveoli, exchanges, picks it up, it goes, and then it goes back out. That's it. You should know that already. So, the impairment of gas exchange, when you have an issue with diffusion of the gases, changing the oxygen to the carbon dioxide, can be because we don't have enough ventilation. What do you think that means? We're in and out. We're breathing that air in and out. We are ventilating in and out, okay? That's movement of the air. Reduced capacity. What would give you reduced capacity? You studied it last semester. Fluid could be one. COPD is a big one, right? Our COPDers, they all get that barrel chest because they're trying to breathe and get the gas to be moved back and forth and in and out. And it doesn't work that way because the alveoli is damaged, right? And inadequate perfusion. What's going to do this? We just did a test on this. Heart failure or acute coronary syndrome, where the heart's not working well to pump. Okay? We just did that. We just talked about those. Okay, consequences. If I have a mild impairment, let's say anybody who have sinus issues, allergy issues, and you can't breathe in and out well, you can't ventilate well, you might have fatigue. Do you feel tired when you have a cold? You're not getting good ventilation and exchanging of your gases, are you? You didn't think about it that way, did you? Okay. You can lead to, if it gets past the mild and starts going into more of a moderate, you can have issues with the heart. Why would it impair the heart and respiratory rates? Your cells are down here going, I need oxygen. They send the signal to the brain. The brain's going to increase the heart rate to make sure that that blood is getting around to pick up the CO2 and burn the O2. However, your respiratory is being compromised by something, so you're going to breathe faster. Because the signal from the brain is saying cells are yelling, let's produce. So it'll raise both, okay? Oops. So more severe impairment, we will go into respiratory acidosis. It's a whole other portion of this lecture. I don't want to go into it now because it's just going to confuse you. Just get it later at the end, okay? And prolonged or severe. So if you're having ischemia, like with the heart, did you have issues with the heart doing its job? So if there's ischemia in the lung tissue, are you going to have a hard time with the lungs doing their job? Okay. You're going to have necrosis, of course. That means it's dying off in there, and we're way past ischemia. I mean, the cells are really dying off in there, which could then lead to your own death, because your cells have to have oxygen to perform. If they can't perform, your body systems are going to shut down, and you're going to. Okay. So these are the groups that are at the greatest chance of having a risk. Infants. Why infants? Lungs aren't developed. What else? I didn't hear you. Their passageways. How big's their neck? Yeah, they're like this big. Not a long area. It's hard. There's not a lot of them. What was the other one you said? They're not developed. Their immune system, the lungs, neither one of those. So they're at high risk of getting sick once they're exposed of getting sick. How about the children?
They're gross.
Otherwise known as walking petri dishes, right? They gotta touch everything, and then if they're really young, it all goes into their mouth or up their nose or wherever. So they're just introducing all of these bacteria and viruses into their body. So they're more at risk. I'm not walking around sticking my finger up my nose after I've gone like this down there. The kids do. Watch them in a grocery store. They'll do it. Okay. And then the older adults. What is going on with them? That's the opposite of the young children. They're not doing that. Chronic diseases. What else? The aging process, which would make their immune system not as robust. I like that word. Not as robust as it is when you're a young adult, middle-aged adult. When you start getting into that older, everything starts happening. That's part of life.
We almost there.
So other than those, just because of age, you get smokers. We talked about COPD and how it affects them, but also that chemicals that are in the tobacco. And I'm sorry to say this, but the vapes also, that should be included in this now. They need to update the textbooks and put that in there because it's really becoming an issue with lungs and getting issues with it. But you're coating the inside of the lungs. Are you going to get good gas exchange? Chronic medical conditions, we said COPD, but cystic fibrosis, your young CF patients, breaks my heart. That was my second patient as a student, and she was ready for sitting there waiting for a lung transplant, and broke my heart. She could hardly breathe. 18 years old. It was awful to see, but their lungs, literally, there's just covered in thick fluids. Can't exchange anything if you're covered up, right? Okay, heart failure, we talked about when we had heart failure that if there's a lot of fluid in there, you're not going to exchange much, are you? Immunosuppression, do the drugs, do they have something to do with that? The diseases that are compromising the immune system, do they have something to do with that? So if that's what happens with you, you are at a greater risk to have issues that would put you at risk of having pneumonia, viral, bacterial, either one of them. Okay, reduced state of cognition. We talked about this with the heart. If they can't get blood flow to the brain, is it going to make them have a reduced state of cognition? Makes it crazy. Not only that, but when we start talking about acid-base imbalance, that too will happen. Brain injury. The brain tells it what to do, right? And if you have an injured brain, is it telling them to do the right thing? Sometimes not. And then prolonged immobility. What happens if we don't get them out of bed? I mean, the lung issues. What lung issue?
Pneumonia.
Atelectasis and pneumonia,
That
right?
too.
What are we doing for that? Isn't that a spirometer? Somebody remembered. Okay. So when we're assessing our patients, we got to get a good history, just like we did when they had heart failure, because there's a lot of things that come out that they don't think about telling you when you're just having this conversation with them about them. People like to talk about themselves. Past history, family history. We want to make sure the counter medications, could they be interfering with this? Yeah. Could be. Lifestyle, okay. We just talked about most of those. Occupation. I worked for Publix for 20 years. I spent many weekends locked in the building, stripping the floors, and then sealing them up, and then go put the wax on, and then we would be there from 8 o'clock at night until 6 o'clock in the morning. And with those chemicals, I now have reactive airway disease. From it. The chemicals, occupation, who knew? And we're sloshing around with that stuff. There, we're gonna get all that stuff off the floor. Who knew? Can't be around things, smells. Shut my airway, I can't breathe. Respiratory zone is like, it's not fun. Seriously, that is exactly what happens. Can't breathe, can't get in, can't get out. So, occupation can be social environment. Anybody, you work at a bar? Wait the tables? Well, they don't smoke so much inside there, but some of the bars still have smoking areas. Would that be an issue for you? Okay. Problem-based history. Are they working in, maybe they're in healthcare, have an immune-compromised disease process, and they're being exposed to a lot of stuff over and over and over again. Is that a problem-based history? Yeah. So, we're going to examine vital signs. Inspection, breathing effort. Are you looking at that when you're assessing your patient?
Yes.
Are they using their accessory muscles to get that air sucked in? Color, their skin. Are they blue? Like gray? Gray's not good either. Okay. Thorax, are they moving it? Is it symmetrical? Is there something going on? And tonight, next week you'll learn. Week after maybe you'll learn about flail chest. That's one of them that you will notice right away. Extremities. Can you get good? Check your cap refill. Thank you. Does that mean there comes pink and it comes back? Perfusion too, but it'll also let you know if there's good oxygenation, right? If it goes pale and comes back, but it's still pale and not real pink again, there's something going on. And then, of course, auscultation, so your breath sounds, you need to be doing it. And please, 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 don't be the one that's writing 16, 16, 16, 16, 16, 16 respirations straight across, because there is no one who is breathing that consistent for 4 days in the hospital. Just saying, okay? The first sign of somebody decompensating is the respiratory rate. So that is where you can save somebody's life and not need to call rapid response if you catch that subtle change in the respiratory rate. So actually count them. When you're counting their pulse, just count it for 30 seconds, double it, and take the other 30 seconds and count their breaths. That way they don't know you're doing it. Okay? How are we going to recognize this? Oh, we're going to test with an ABG. We have troponin for heart, right? AMP for heart failure. And now we have ABGs. That's going to give you a picture of what is going on with the arterial, which should have the highest levels of oxygen, right? It hasn't gone through the bile yet. So it should have the highest levels. Sputum, especially if they've been coughing up green stuff. We like to test that, because it could be Pseudomonas, especially if it stinks. Chest x-ray will give us an inside picture. We're going to look at CT MRI if this is showing something and they can't definitively say what it is. A VQ scan is going to look at the perfusion ratio of in and out and oxygenation. Pulmonary function test. Everybody who has open heart surgery has one of these before they go. Why? Baseline. If they don't have good pulmonary function test, are they going to risk putting them on a ventilator or a heart bypass machine? No. They'll do a lot of pulmonary treatments to get them up to par if they can. Sometimes they can't. And endoscopy. They can go down and take a look. Bronchoscopy, actually. Okay? All right. So, nursing and collaborative interventions. Our collaborative interventions is going to be #1 with your respiratory therapist. Make friends with them on the end. They can be your lifesaver, or their patient's lifesaver. So, we are going to practice hand hygiene #1, right? To prevent bringing in stuff to your patients who may be compromised with some other illness going on. We want to make sure that we're doing. If you're dropping their oxygen tubing on the floor, are you going to pick it up and put it on their nose? No. Please don't. Don't get new tubing. Smoking cessation, we're going to do education on that, immunizations, especially for your people who are over 65. Which one should they get? Pneumonia, yes. And then preventing post-op, what are we going to do? Post-op. NSAIDs. Yes. All right. So, our secondary is going to be, you all have to have it done, don't you? Every year. I hunt us down just like I hunt you do. TB test. So how do they do it?
5 units of.
They pull it up into a tiny syringe and they stick it up just under the skin and get a bubble. Have any of you been able to practice that?
No, ma'am.
Ooh, that might have to work. We might have to do that. I know. We might have to work that into this lab portion of our. Yeah? Okay, so who should be screened? Healthcare workers. Oh, yeah, I want to make sure that I'm not going to give somebody something. Right? If you're elderly, if you're immunocompromised, all of these people should be looked at and screened for clinical management. So, how does this screening test link to gas exchange? What happens in terms of TB? Come on, give me a quick little, you had this already. What happens in the lungs with TB? Spots. Spots on the x-ray, yeah, you can see that. It encapsulates portions of the lung that there's no gas exchange happening yet. No good that, right? And you get enough of them, they're O2, and it's very contagious. And now they even have one that's not responding to the antibiotics that they give to treat it for some months. So, prevent it. Keep yourself washed, hand hygiene, infection control. Okay, so interventions again, we talked about the smoking cessation. Does that mean I have to do it? Well, I'm going to start it. Get them into a group. Quit smoking them outside. Get them hooked up. Give them the information. And we're getting ready to leave. Pharmacotherapy. There are medications that can help them breathe. There are medications that can stop smoking. There's all kinds of things for pharmacy. So get your pharmacy on board with you and help them provide the education that your patient needs. Oxygen therapy, they may need to take it home. Airway management and breathing support, and it's not just oxygen tubing, it may be a CPAP or BiPAP machine. So you'll need to work with the social worker to get these things delivered to their house. Chest physiotherapy, who needs that? Fibrosis, yes. Postural drainage, how do you do that? High Fowlers? Did I hear that? How about Trendelenburg? Stand them on their head, help get this to be coming this way. Yeah, makes sense, right? Head down here, let's the lungs drain down this way. Okay. Invasive procedures, they can do chest tubes. You will learn more about that with Professor Sledge. Thoracentesis also, and bronchoscopy is where they stick the tube down, goes into the bronchial, they go into the lung. They can get a biopsy, they can deliver medication right into the area that they need to. It's very invasive though, right? They run the risk of infection, so if they're already sick, would they get something quicker? Because their body can't fight it off. Okay, nutritional therapy is very important, and positioning. That's where the high power comes in. They're having trouble breathing, you want to sit them up, that's it. Helps those lungs expand. Interrelated concepts, we're going to do acid-base, we've already done perfusion. Anxiety, if you are not getting enough oxygen to circulate in your body, is it going to start sending the signal to the brain, help, 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 help? What's it going to do to you? It'll make you anxious, very anxious. Mobility, you're fatigued, you're not going to want to be mobile, are you? Your COPD patients, when they're in the middle of an exacerbation, are lucky to make it from here to the end of this table, because they can't get that air moving in and out. And then again, nutrition. Asthma, you should have already covered. COPD, pneumonia. We talk about lung cancer in another module. Anemia, our transport, right? That's our transport to get that oxygen around the body. Very, very important. And a pulmonary emboli, PEs. If you're blocking off the blood flow to a certain section of the lung, is it going to work? Is that going to decrease your oxygenation? Is that going to make you short of breath and fatigued and so, all right. Well, that was the first one. That wasn't so bad, now was it? You got questions on this one? It's pretty simple. It was common stuff you should have already covered, right? All right. I know, like. Well, you can make it bigger on your screen by doing this, you know? Okay, that's not tiny. Okay, PE. So what is happening when you have a PE? I kind of just described it to you, right? And you've already studied this in the other previous course. I'll just leave it at that. Okay, but it's particulate matter that gets into there, that lodges. It's not going to go anywhere. It's just like having a blood clot in your heart, only it's in the lung. Same thing. So anything can cause it though. It can be fat, it can be cholesterol, it can be blood, it can be virus, it can be bacteria, it can be a piece of tissue that watched from somewhere else. Never know. Until they go in there with bronchoscopy, pick that little piece out and find out what it is. Okay, so this is what happens when you have an embolus. It comes in the circulation from behind the heart field, feeds into it, right? Sends it out of the right ventricle into the lung, and here it has lodged. Now, all of this tissue here, you can see where it's not getting the oxygen it needs, the blood it needs to exchange and be fed. It infarcts just like the heart. So if we can restore the blood flow, can we restore that tissue in an infarcted area? In ischemic?
No.
It's too late. We can get it. We can get it. If they go in with a bronch, go in and down and go in here and they grab it and then start them on anticoagulants. Sometimes it's so far down into the little ones they can't. So then they just put them on heparin and they're in the bed for a long time because they don't want to give it up. Have it start dissolving or not being sticky, and the body should be taking care of it, right? The little macrophages and eosinophils and neutrophils, they're gonna flush it out. They don't want it to break loose and lodge somewhere else. So most of the time, they will have these patients on bed rest while they're doing this. Because they don't want it to move, you want it to go to the brain. Not good. So it gets lodged, we want to get it out. All right, so what are the risk factors? Well, prolonged immobilization, this is why we want to get them up as soon as we can out of bed after surgery. Or any hospitalization, it doesn't have to be just after surgery. You have a patient that comes in and gets admitted, and they're pretty sick for the first 24 hours. You start treating them and they start feeling a little bit better. Get them to the chair. Doesn't mean you have to walk them down the hall. But get them up out of bed, pivot to the chair. Get them moving. Get those muscles moving. If you need to, who else can help you get them moving? PT. Get a PT consult. If your physician has not ordered it, ask them for one. You can't be in that room 24/7 with this patient. However, you can do the little things like getting them up to the chair, sitting them up for breakfast and lunch and dinner, but they can get them out and can help walk them because there were two of them to help support this patient. You think you're going to get you and another nurse to help walk that patient down the hall 3 or 4 times a day? But you can probably do it once. Every little bit's going to help. Get them moving. Central venous catheters. Why would that be an issue? Infection? What about just a blood clot forming around it? Because it's a foreign object, and what does the body want to do with that foreign object? It wants to isolate it and get it out of there. Now, it's not going to do that, but it's still going to try. It doesn't know it can't get it out of there, but it's going to try. So it's going to form a blood clot around there, and then that can break loose and travel elsewhere in the body. Surgery. Infection. Blood clot from immobilization, maybe? What's the body's reaction when you cut it? Clot. It wants to clot. So it's going to put out the signal to the body to make clotting agents to fix what we just cut into, right? Get in there and do it. Can it overdo it? Yes. It can overdo it and send the body into DIC. Told you I would talk about it in a later lecture. It sends the signal to the body to, we need to stop this bleeding. Can be caused by infection, can be caused by surgery, can be caused because there's a blood clot in the body. Usually that's one of the causes. And it overproduces the clotting factors and uses them all up. So then you have wounds that just start oozing blood because there's no more clotting factors to stop it. So they've got to stop that. So what do we do? You put them on a heparin. I see some puzzled looks. What it does is it fools the body into thinking, we want the blood thin, don't make clotting factors. So it just does its regular making the clotting factors that it normally would do, but wouldn't be doing the overproducing, overusing of it, because it uses them all up before you can even clot off where there's been bleeding, or what caused it. So you keep the blood thin, it fools the body has time to fix it. Now I'm going to tell you that DIC is about 50% fatal. If they can catch it in time and get the heparin started, they got a better chance of saving your life. But if it gets that far, they just bleed out. And then they start bleeding from everywhere. Nose, mouth, urine, bowels, everything just starts with blood. So that's disseminated coagulation. Nice. Okay? It's not all you really need to know about it. Scary. Okay, so pregnancy. Why? Go back to your OB days. Think about it. You hemorrhage. You can hemorrhage, right? Do you remember doing that sim? Did you do that CJ sim where you had the little bed and she's bleeding?
Sure.
No. Okay, they have one of them. She does postpartum hemorrhage, but they can hemorrhage. Again, they can go into DIC also. But what if normally, if it starts bleeding, it's gonna coagulate and it can cause a blood clot and it can break loose and go into the lungs. Okay? Obesity, are they mobile? I mean, do they get up and move like they should after surgery or in the hospital when they're sick or anything like that?
No.
Okay. Advancing age, now we don't wanna get up and move either, I'm just gonna tell you. We're not doing it. Okay. Same reason though, they're not getting up and around, they don't have good circulation, probably have some other comorbidities in there that are preventing it from happening, from getting up and moving, preventing a PE. General or genetic conditions that increase blood clotting. Somewhere down that blood cascade, the clotting cascade, they have some interruption with the disease process, and it can cause clots, depending on which one it is. There's several. You don't need to know that, you just need to know that it can. One of them can, okay? History of having some. If you had it before, are you likely to have another one? So how are we gonna fix this? The best way we can. We're gonna do smoking cessation, teach it all the time, right? Reduce the weight, get them up. When you're not carrying around, I mean, every 5 pounds is like a bag of potatoes. You wanna walk around with a 5-pound bag of potatoes all day? Imagine, in my case, it's a lot of them. But it makes it easier to get around when you lose it, so we wanna get them to lose it as much as possible. Traveling, plenty of water. If you are dehydrated, is the blood sticky? Or is it loose?
Sticky.
It's sticky, right? Doesn't have enough dilute in there. So you want to make sure you're drinking plenty. I know you don't want to do it when you're driving because you gotta stop at every rest stop down the highway. Do it. And do your exercises. Remember them from the heart lecture? Do those. Get out every 2 hours. Avoid crossing your legs. How many of you have been told as a young lady that cross your legs? Yeah. Don't do it. Cross them at the ankles. Best thing you can do. Don't. This is bad. Let's see. Get up, traveling, I already said that. Moved or flights or in the car. We're gonna talk about this. You already knew those from the car section. There you are, same picture. So how do we find out that somebody's having this? Well, besides gasping or pain, they're gonna have a high respiratory rate. They'll start using those accessory muscles to breathe in and out. Cardiac rate will go up. If the heart goes up, what happens to the blood pressure? It goes down. They'll be anxious. Again, the cells are going to be yelling, I need oxygen down here, and that's going to tell the brain can't get it, it's telling it to move, and everybody's in there in your body going. I love that the second movie with all those little things in their head are coming out from Pixar, the emotions and all that. It's exactly what's going on when this is happening. Just picture that, all of them up there, like in the control box and not being able to get any of it to work. That's what's happening. PaO2 and AG, we'll talk about that in the ABG portion. Labs, we're going to run a basic metabolic panel. We're going to probably do a CBC on this because we want to see what their hemoglobin. Troponin, it might be a heart attack. We want to rule that out before we think of that. It might be the heart, not the lungs, because they're so intertwined. Okay, and then our BNP, are they in heart failure? Because then we might have fluid in the lungs blocking it, getting that exchange. Yes? Okay. D-dimer. D-dimer is one of the tests that will tell you that there is some coagulation bad going on. Is it specifically for a PE? No. It could be a DVT. It could have had surgery and it might be elevated because there's clotting agents in the body doing this. Does that make sense? So as much as the BNP is indicative of heart failure, a D-dimer is indicative of having some clotting issues, but it does not say, yes, you got a PE. But you could have a DVT. It takes further examinations for that. Imaging, there you go. You'll have a CT or an MRI. An MRA is a little different than an MRI. I is just the image, A is the angiography. It's looking at the actual blood vessels. Okay, it's an MRA. Usually they'll get an MRI/MRA and do it at the same time, but yes, they're different. So what are some of the cues? Hypoxemia. We will see that when we run, what? Geez, what you learn. Hypotension, easy to tell, we do that by checking blood pressure. Potential for excessive bleeding. Would this be part of the history you take from your patient? Yeah, that clue of maybe I've had these before, or I'm on these medications that might cause it, or I eat a lot of greens and I'm gonna eat a lot of potassium, or whatever, what's going on. The only way you're gonna find out this stuff is by doing this history. Anxiety, we talked about that already. Implementing solutions. Well, if I want to manage hypoxemia, what's the first thing and the easiest thing you can do when your patient has low oxygen?
Supplemental.
Put them on. Okay, and it does go up here and over the ears and under the head, right? I mean, under the chin. We know that, correct? Please tell me you do.
Yes.
Lie and tell me you do. Because now you do. Okay, good. Hypotension, well, how are we going to manage that? You're going to do what? Fluids. I'm going to give them fluids. And if it's severe enough, what can they give them? Vasopressors. There we go. Control the bleeding. If there is bleeding, we're going to try everything we can to stop it, which means either putting pressure dressings on them. We may need to give them vitamin K as related to some cascade and the blood clot that they may need to have some extra vitamin K. They might have on Coumadin, something to that effect, right? Vitamin K. And go to Coumadin. That might pop up on an NCLEX question or two. And minimize anxiety, because if you can calm them down, you reduce the effort of breathing. Is that going to allow further expansion and ventilation? Would that help then with getting that oxygen in and out? Get the anxiety under control, and will help greatly. Okay. Care coordination. So, home care management. We might need to get oxygen delivered to home. We might need to get nebulizer home, because what if they're having COPD on top of a PE, because that might cause a PE, right? We talked about that already. So you may need to get the social worker to get a nebulizer and respiratory care to come by and deliver and show them how to do that. Right? Okay. Self-management education. Good. Quit smoking. Eat right. Get up and move. Use your incentive sponsor that you go home with. If you don't take it home with you, we're going to throw it out. So you need to take it home with you. Some people have like 4 or 5 in they'll say, I already got 4 or 5 in my closet already. Well, are you using them? They're not doing any good sitting on the shelf in your closet. Healthcare resources. A lot of people can't afford to have those machines at the house. They may need to have the one that looks like a dehumidifier, but that's actually an oxygen concentrator, and they run with a long tube and they just walk through their house and use this tube. Careful not to step on it when you're in there, because that would not be good. Okay. How are we going to evaluate what we're doing? What's our work with this patient? How do we know whether we're successful in either educating them or actually getting the resources that they need? We're going to make sure when we visit, home visits, you won't be doing it if you're in the hospital, but the home health nurse will need to be there, and they're going to be doing gas assessments, gas exchange assessments on them. That would then trigger them, do they need to come back to the hospital? Do they just need to go have a lab? Do we need to maybe get a different type of respiratory medication? So assessment, again, becomes number 1 in this care management on them, and that's how they're going to do it at home. They have machines now that will talk back and forth with the doctor's office, and they may have an appointment that the nurse at the doctor's office is watching for everybody to send their data in. They all have to take their blood pressure, but get their oxygenation, and they will be able to see that. So that may be something you need to coordinate up above, is get one of those telehealth being set up for them. That where we can manage to see if what we've done up here has actually maintained their gas exchange here. Maybe blood thinners, but educate them about those. Anticoagulants, not blood thinners. Okay, how do we make sure that they don't get hypovolemic and go into shock. If they're bleeding, we're going to control the bleeding, right? Tell them what to look for if they're at home, what is going on. You know, hey, you see this and it's not stopping. You put pressure on it, it's not stopping, you better call 911. Because we need to control that. We need to make sure they're taking in enough fluid. Especially in post-surgery, you know, we make them get up in the hospital. Who's making them get up at home? PT that comes like 3 times a week? That's not enough, is it? Enlist the help of the family. Remain for your bleeding episodes, again, it's teaching them what to look for and how to be careful maneuvering and moving around. Changing dressings. Maybe you got to teach them how to change that dressing so they're not just ripping it off and then they start bleeding again. Or somebody else who's changing. Anxiety levels. Sometimes the hospital will arrange for the telehealth people to call on them just to check on their well-being. Maybe they need to have an anti-anxiety med added to their regime of medications post whatever hospitalization. And then using the coping strategies. Do we need to teach them how to tripod and breathe? Especially if they have COPD, right? We want to help them get the oxygenation back under control again. No way? Pursed lip breathing, breathing, not bleeding. Okay.
That's not nice. You
So, clients being discharged to home on warfare therapy after an acute. Which client response indicates a need for further teaching by the nurse? Is it A? Anybody think it's A? Anybody think it's B? How about C? How about D? How about you waiting for the right answer? How about I'm not going to tell you?
Aww.
Well, I can think about it. Bless you. Stay away from me. Maybe it's B. Yeah. Let's hear it. What do you think?
B.
Why do you think it's B? Because of the green tea? For the cranberry juice?
it could be.
Do they need to do this?
Is it weekly?
Here's
I
the
don't
key
know.
word in that, right? Do they need to go weekly?
No.
Okay. Do they have to take the medication at the same time every day? They should, but is it imperative that it's done at 3 o'clock or 3:05 every single day?
No.
But I still think I like this, I'm gonna hang on to it. How about drink more green tea? What is in green tea?
Caffeine.
Caffeine, is that good?
No.
Will that dehydrate them?
Yes.
Will that make them hypovolemic? Will that make sticky blood?
Yes.
Do I want them to drink alcohol? Will that thin the blood? On top of their anticoagulants, would that be bad? Alright, so what do you think it is?
B.
I want to take it around the same time every day. Be consistent.
It's further teaching. Further teaching. Which one's wrong?
Okay. So we want it to be, the correct answer to be
B.
all of them, pretty much, right? No. This, I should limit is good, right? I should drink more green tea,
No.
but I should take the medication at every time, right?
Yeah.
And I should make an appointment. Just keep me on your toes. You're not responding to me, so I will make you work for it. All right. Just say it. I should drink more green tea. Yeah. But nobody's like, they're all like, oh, come on guys, wake up. I know you had needs, most of you. Let's wake up.
She just made my brain hurt so much.
Okay, all right. Break time. 10 minutes, go.